Hello, it's a real pleasure to be here today to talk about living with primary biliary cholangitis. My name is Professor Gideon Hirschfeld, and I am the director of the Autoimmune Liver Disease Program at UHN's Francis Family Liver Clinic and the Lillian Terry Horner Chair in Autoimmune Liver Disease Research. I'm joined today by Professor Sonja Stander, Professor of Dermatology and Neurodermatology at the University of Münster and head of the Interdisciplinary Center for Chronic Pruritus at the University Hospital Münster in Germany. Welcome, Professor Stander.
Thank you.
We're also joined by Mrs. Colette Thane, MBE, founder of the PBC Foundation and a person living with PBC from the UK. Welcome, Colette. I am delighted to have you today.
Thank you. It's a pleasure.
In this section, we'll be considering patients' experiences of living with pruritus and PBC. Those looking after primary biliary cholangitis will know that the symptom burden is very important to patients. Amongst that symptom burden includes cholestatic itch or cholestatic pruritus, almost certainly affecting more than 20 to 30% of people living with PBC, and really can be a devastating symptom with real impact on quality of life, the ability to sleep, the ability to function, and really a chronic burden over time. Managed by their primary gastroenterologist or hepatologist often, we are sort of limited in our choices and really excited at the prospect of new opportunities for treatments. We're joined today by a dermatologist, which allows us to really get a different insight into pruritus and some expertise that is often not available to everyone. So, I'd like to turn to Professor Stander and just to listen to her perspectives about how common cholestatic pruritus is in PBC and from her experience and her practice, and really, some of the features that she's seen in clinic when she's talked to people living with PBC and cholestatic pruritus.
Yeah, Gideon, thank you very much also for having me in this wonderful discussion together with Colette. So I come from a totally different perspective. We have an itch center, and patients with itch of any etiology come to us. And so we have a view from outside. The patients come to us, they say, I have generalized or localized itch along with severe scratching. And so what we see at the skin in the beginning is sometimes nothing, and sometimes we see severe scratch lesions or a dermatosis, then the case is clear. But in all other cases, we have to detect the underlying etiology unless this is not yet known. And sometimes we detect a liver disease. In most cases, it's a hepatobiliary liver disease with cholestatic pruritus, such as PBC, but also others. In many cases, patients, of course, the PBC is already known and they come for advice what to do against severe scratch lesions or for optimize the treatment. So what is very interesting is that in these patients, they tend to rub more than to scratch. And sometimes we see this lichenification as a result, that their skin is thickened and a little bit brownish. And it is very typical in our patients. We see that the patients have this lichenifications on the lower arm, for example. The itch starts frequently on the palms and soles, but then the extremities are involved. This is what the patients tell us.
So that's very interesting. And just from a perspective, in terms of severity, how does it compare sometimes with other causes of itch that you see? Because certainly in our experience, in our clinical practice, gastroenterology, hepatologist, and I really would like to hear from Colette in a second, it can really be quite significant and quite devastating. So Sonja, do you see that as well? You see some patients whose quality of life is really impacted.
So in the range of all these patients we see, we have dermatosis, we have neuropathic entities, sometimes we have psychiatric diseases, but the systemic entities we see are among those with the highest itch intensity. And next to a cholestatic pruritus, it's CKD-AP, so chronic kidney disease associated pruritus. And these patients really suffer a lot because also it highly impacts the sleep. So sometimes the itch gets worse in the evening and the night. And no need to say, when you are itchy in the evening, you cannot fall asleep. Or when you have fallen asleep, your sleep is disturbed and you wake up and you have this scratching habit. You must scratch yourself. And this also disturbs a lot of the quality of life for the day, for the working capability, and so on. And sometimes cholestatic pruritus affects also children with congenital liver diseases like Alagille syndrome. I hope I pronounce it correctly. So we also see sometimes these children, and they are really highly burdened, and you see that they are smaller compared to other children in the same age. The treatment aims patients have, it's not the symptom itself, it's the burden, the quality of life, what doctors are also aware of, but there are multiple more dimensions, such as the sleep quality and also the approach to therapies, approach to centers, and making the doctors aware about the problem, because sometimes you don't see the itch at the skin, but they feel it.
Okay, so I think that's a perfect segue to go to Colette, who really has a lifetime's experience as a patient and an advocate. So Colette, from your sort of unique perspective, what do you think the impact is of itch for people living with PBC?
Well, I've been speaking to people with PBC for 30 years, and I need to start off by saying, you know, they're told they have this incurable progressive disease, and that has a massive impact before you even look at the symptoms. But the itch, the PBC itch as they call it, I've never known people to have it mildly. It's been relatively severe to extremely severe. And it has such a major impact, as Sonia was saying, you know, about sleep, etc. And I've known people to take things like a stone to the surface of their skin to scratch it. And of course, they're making it worse by causing abrasions on their skins. At very worst, I know of 3 suicides in 30 years because the itch could not be treated. And due to those suicides and other factors, I know the rules and regulations regarding liver transplant were changed, and they will transplant if the itch is so severe that it affects every aspect of your life. And it does come at night. It absolutely does come at night. It's like ants under the skin, crawling under your skin. And for many people, medicine just isn't effective. And of course, the less sleep you have, the more tired you become, the less you're able to cope. It's physical and it's psychological and it's emotional. And to put that in with many women with PBC and the menopause, lack of sleep, it is a very difficult scenario. I know it's been effectively treated for people who have had a transplant because the itch has been so severe and untreatable, and it's had a massive positive impact on their lives. But again, having a liver transplant, that brings its own difficulties and challenges too. So my heart always thinks when I hear about, when I lift the helpline and I hear about people's itch. And if you're attending a hepatology centre, there is a regime that hepatologists will take you through in terms of various treatments. But some people don't get near hepatology centres. I mean, I've heard of patients be given antihistamine, which really is of no use whatsoever. So I'm glad at least we're there and we can guide people and direct them and, you know, persuade them to ask for various things from their clinicians. But that again is another issue people have to deal with. Nobody likes to, you know, ask for medicines. They like it all to be offered to them, but it does have a big impact. It's very unpleasant, and many people tell me it's actually worse than pain.
I think that's a really helpful description for us, and it really also frames the sort of the way we have our treatment goals in PBC and the excitement we have with the new therapies that are coming online in 2024 and beyond, that we're going to target basically people's blood tests, but we're really going to target people's symptoms as well. And we're going to try and do that in alignment, because I think what I heard was that there are challenges and unmet needs for people still living with PBC. And I think if I paraphrase what you said, Colette, is that, you know, if we get better treatments that will tackle itch directly or alongside also improving the disease, that's really something that patients are going to be interested in. But moreover, patients want to have access to those centers with the expertise to get that treatment, and the collaboration that we heard that you can have with a dermatologist who can also give you other tips. And so that sort of collaboration between the GI hepatologist, the dermatologist, and the patient in the middle, okay, advocating and listening, and new treatments really hopefully sets us up for success. And I think that probably really gives us a good starting point from today to listen to what the burden of cholestatic pruritus is and why it's so important that our audience continue to listen to episodes like this to hear about what's coming in the future.
And it's worth noting that these patients who suffer the itch, they're very, very keen to take part in research. Very keen.
I agree. And more to the point, it's the research that's driving the new drugs. So I absolutely want our patients to continue taking part in research, but it's even more exciting that actually the research is paying off. So with that, I think we really have described, in just over around 10 minutes, the burden of cholestatic pruritus, the lack of awareness, and the absolute paramount need to address that symptom in a collaborative partnership. Thank you.
Hello, welcome to today's discussion. Thank you for joining us. My name is Michelle Clayton, and I'm a liver nurse educator at the Leeds Liver Unit at St James's Hospital in the UK. And I'm joined today by Professor Sonia Stander, a professor in dermatology and neurodermatology at the University of Munster and head of the Interdisciplinary Centre for Chronic Pruritus at University Hospital Munster in Germany. Welcome, Professor Stander.
Thanks for having me here. Welcome.
And also I'm joined by Professor Gideon Hirschfield. He is Director of the Autoimmune Liver Disease Programme at UHN's Francis Family Liver Clinic and Toronto Centre for Liver Disease in Canada. So welcome, Professor Hirschfield.
Thank you so much, Michelle, for having me here today.
Thank you both for joining me, because in this section we'd like to consider symptom assessment and monitoring for cholestatic pruritus in clinical practice for patients with PBC. So I wonder if I could start with Sonia and to ask you, so what do you think are the important factors that should be included in an assessment?
Yeah, thank you very much. So when we think about cholestatic pruritus in patients with PBC, this has many dimensions. It's not only the symptom, it's only the functions such as sleep disturbance and quality of life disturbance, emotions up to reactive depression and anxiety, but also the need and wish of the patients to have approach to modern therapies, to expert center, and so on. And when we think about that, this gives us a lot of opportunities to assess the pruritus. But in these psychometric studies, we always found out that there is one surrogate that really reflects the burden of the patients by this symptom, and that is the itch intensity. And for that, we have several instruments that we can use in daily practice and even in clinical trials. And what makes it so charming is that we do not have to think about assessment of the scratch symptoms we see at the skin, because this shows individual variations and it's hard to measure that. And so we can ask the patient very simple and easy, how is your itch today on a scale between 0, no itch, to 10, worst itch imaginable in the last 24 hours. Yeah, and this gives us very good data. We can also ask about the average itch, but we can also give patients a paper with a line of that, and then they can make a cross. This is then the visual analog scale. Before, what I described is the numeric rating scale. And so there are other options which are all validated with different ranges, like, for example, from 1 to 7, the patient global impression of severity. And when we think about treatment and clinical trials, there's also a patient global impression of change. and the patient can give us his judgment on the treatment efficacy. And all these instruments are very, very useful. But the most important factor is we have to use instruments, because we cannot see how severe the itch is by just taking a look at the skin, because it can be that we see nothing.
So we can have two impacts. One can be that we don't see anything in skin integrity, but these individuals have significant itch, but also then we can see those that are clearly disrupting their skin integrity, and that is much easier to identify. I wonder if, looking at these tools, could I ask you, what aspects do you think should be taken into account?
Yeah, thank you for asking. So next to the intensity, we have a lot of other factors that we can assess. And here we also have some itch questionnaires that can help us, and the patient can fill the questionnaire in by themselves. So what is important is, of course, the duration. So if there is pruritus that lasts 6 weeks or longer, we term this chronic pruritus, and we have to look for the underlying etiology, for example. For us, it's also very useful to know where does it start, because there are several patterns across different itch entities. So, for example, we have in diabetic pruritus, it starts usually at the back. In cholestatic pruritus, this can start at the palms and soles. Yeah, and in atopic dermatitis, of course, there we see skin lesions, but this can start at certain areas, which are very typical for the dermatosis. What we also ask, what we want to know is the triggering factors that the patient reflects a little bit. When does the itch get worse? Is it under certain stress conditions? We know it's getting worse during night, at the night, in the evenings. And these are all triggers that can increase the severity. And that's also important for us to know when we are discussing treatments. Now, when the patients say, I have the impression there is no change, though I have a treatment, then you can elaborate. Are there factors in the past that triggered it? Did you had a lot of stress? Were there any familiar problems? Or was it very warm? Or in some diseases, it's getting worse in the winter time. And so there are more and more factors we can discuss. But I think this gave you already a good insight that it's important to listen more to the patient or assess it in a structured way via questionnaires.
Thank you. Thank you very much, Sonia. And I think that's very important, that we absolutely need to be listening to the patients and for them to be able to recount their experience. I'd like to bring in Gideon now and ask him, as a hepatologist, from a clinical perspective, how would you be assessing and monitoring the symptoms of the cholestatic pruritus?
Well, thank you, Michelle. I think I like the term global, and I like the term repeated when I think about that question, because I think you have a relationship with your patient that goes on a long time. This is a chronic disease that people living with PBC are dealing with on every day, and with our therapies are living long lives, but their symptoms are reducing the quality. So the way I tackle it is, as I get to know my patient, is I have a general assessment which comes from listening and asking. So you listen passively and see what the patient raises, but you ask specifically about symptoms, but you including itch. And that gives me that sense for the burden, the pattern, the frequency, and how important it is to that individual. It then allows you to also think about how you might use the different tools and interpret those tools when they've been used in clinical trials, for example, because some of the tools are very, very robust at measuring quantity. So they're really measuring the severity. So if a drug can improve the metric, that means the drug's doing something. That's a marker of potency. Okay. But on top of that, because symptoms are so complicated, and as we heard, sometimes you can see the scratching and sometimes you can't see it. You then have to have tools that are also measuring the impact for the patient. So you quantify it in a sort of linear way, and then you try the much harder thing, which is much more personalized about what does that mean for that individual? What's the overall impact? Because we know that for individuals, just because the quantification is a bit lower doesn't mean the impact isn't higher, okay? Because they're individuals, they're different. They've got different lives, different diseases, different experiences. So I'm sort of aligning what I hear. I'm aligning the potency, the severity in a very, very simple way. And then I'm thinking about the impact from the more complicated tools that are framing it really from the patient-centered approach, which is regardless of the quantity, what does it mean for me? And in that way, I'm able to assess the patients who have got itch and help them make the decision as to what treatments they should be considering to improve the itch, but also thinking about, when I see them again in 2, 3, 4 months' time, because I'm going to look after these patients for years, has my intervention helped or not helped? And that actually ultimately leads to better care for our patients. I think patients prefer that. They feel that they're being listened to. They don't expect us to fix everything immediately, but in that journey, incrementally, plus with the opportunity of new drugs, we really will, I hope, make a difference for individuals and really for everyone living with PBC wherever they find themselves.
May I add, Michelle, I really like what Gideon said about the scratching. Scratching behavior is very individual. And what you can read from the skin is just the scratching behavior and not any disease. And we can imagine that the patients observe this by themselves, and so they feel ashamed that they produce these lesions. And this is also something what really hurts them and produces shame and gives pressure from their family saying, do not scratch, because the family also observes that there is this scratching behavior that damages the skin. And so in this sense, we as caretakers should not instruct patients, do not scratch. This is really something very, very essential, because it's producing more and more stress for the patient.
Yes, and I think that's really important, isn't it? That although we can see physical symptoms, there are a lot of emotional and psychological components to having chronic pruritus. I was just wondering what your thoughts are on patient diaries and whether you find that helpful.
But I think it's one of the many tools that we should be empowering patients to think about. And for some patients, they'll find the documentation of their symptoms to be helpful. In other patients, it's not something that, resonates with them and how they sort of lead their busy day-to-day life. So I think, there are apps out there for symptoms. The PBC Foundation has an app. So I signpost them to those organizations and those opportunities. And I say, maybe you'll find this helpful because it will give you the content for the next discussion when we next meet. And that empowers that individual, as other patients are, more able to freely tell me how they feel and the effect of their intervention. I guess the real big point is, awareness and toolbox, and to just think that your toolbox can use different things at different times for different people. And that's how we will make impact.
And I think very much I'm hearing from both of you how important it is that our care is person-centered and that we are taking our lead from the individual who is experiencing the chronic pruritus, whether that is visible or not. And it's about the impact that is having on them, and then looking for us to be able to support with different treatments and to look at the effectiveness.
Welcome everybody. Let me welcome you to this exercise on the comprehensive approach to symptom care in PBC. My name is Sonja Stenner. I'm a professor of dermatology and neurodermatology at the University of Münster and head of the Interdisciplinary Center for Chronic Pruritus at the University Hospital Münster in Germany. And I'm very happy today to welcome here Michelle Clayton, liver nurse educator at the Leeds Liver Unit St. James University Hospital in the UK. Welcome.
Thank you. Nice to be with you.
And I'm also very happy to welcome here Professor Gideon Hirschfield, the director of the Autoimmune Liver Disease Program at UHN's Francis Family Liver Clinic and Toronto Centre for Liver Disease in Canada. Welcome, Professor Hirschfield.
Thank you so much for having me.
And last but not least, we are joined today by Mrs. Colette Tain, MBE, founder of the PBC Foundation and a person living with PBC from the UK. Welcome, Colette, and we are very happy to have you here and sharing your experience.
Thank you very much indeed.
In this section, we will be considering a comprehensive approach to care for patients with cholestatic pruritus and PBC. And first, I would like to give the word to Colette to tell us a little bit more about her take on tips for patients with cholestatic pruritus and PBC and introducing us the patient support group.
Thank you. Yeah, patients have their own tips that they swap with each other, and I've heard some incredible things. Nurses, liver nurses will always say try and bath in Epsom salts, or rinse your hair in Epsom salts if it's affecting your hair. I've heard people tell me giving up sugar in all its forms has stopped the itch. Christmas has come, back on the biscuits again, the itch comes back. It works for some people, the reasons we don't know. I've heard of people using anti-dandruff shampoos as a body lotion. So people have their own experiences, and these kinds of things, they sound sometimes a bit unusual, a bit strange, but if they work, for some, it's worth a go, really. So I'm always very interested to hear what people have to say. The PBC Foundation, it's got a global reach. I think our website's in 20 or different languages now, and people communicate, they swap stories, they support one another, they understand one another. And of course, on the other side of that, we have a worldwide medical advisory board. Professor Hirschfield is on that board and has been on that board for many years. So we have the best quality information going out. It goes electronically, and we still do things in written form. But one of the most important things that we do, and that we have done since COVID, we will have a live session with a hepatologist from around the world. Gideon's done them for us every Thursday, 2:00 British Summer Time, or GMT time. And we will have a live session where people can ask questions. Not everybody gets access to a hepatologist or a specialist, and they can ask and people can share information. And then also they are getting the best information available by speaking to a world-class hepatologist. So it's a network that works on all levels, patient talking to each other, but patient, hepatologist, patient, doctor. There's no gap now like there used to be years ago. Your hepatologist is your partner, you make decisions together, you discuss things together. So the itch in particular is very difficult to treat for many people. So I think having the facility to listen to other patients as well as doctors is very helpful. And we also, as Gideon mentioned, we have an app, and people, if they want, they can put in that app how their itch affects them, because sometimes when you go and see a doctor, it's difficult to articulate how it is you feel. You're upset, you haven't been sleeping, you're tired, it's difficult. Whereas if they have a measure on their app or something on their diary to say, this is what's been happening since I saw you last, that's helpful to them to talk about it, to be believed, and it's certainly helpful for the clinician in treating the patient.
Yeah. Thank you, Colette, and congratulations for having this patient support groups. This is very, very important for patients to see that they are not alone with their disease. So, Michelle, in your experience, how long do these patients have problem with itch, and what are your takes on tips for the patients specifically who have itch?
I think it's really important that you work in collaboration with the individual, and for them it might be about using a scale or rating for itch, which we've covered in a different section. We also want to just revisit education, particularly on skin integrity and importance, because this is one of the real challenges. And, as Colette said, things like moisturising the skin, because it can feel very dry, it can feel very warm. Use of cotton or natural fabrics can be helpful. Try not to use a sharp implement. Sometimes patients do use implements, but try, maybe something that's blunted, so you're not doing as much damage to the skin integrity. I think as well that, there are different things that patients will say. Sometimes they find aqueous cream that's mixed with menthol can be very cooling on the skin, and I think Colette's probably alluded to something like an anti-dandruff shampoo tends to be a menthol-based sort of product. But I think as well as a liver nurse, what's really important is that this is a holistic approach. So I think also we've got to look at the emotional, the psychological, as well as the physical. So, and it's not just about itch, it can be about fatigue, it can be about mucosal dryness as well. And these all have impacts on the individual. And also I think we should remember that for some patients, it's very dark times when they have this significant, overwhelming itch, and we shouldn't underestimate the impact of that itch on those individuals. So I think, having support and finding support is really important, and also making sure that when we're delivering care, that it's a symptom-led approach, and we're really have the patient at the heart of what we're doing.
Michelle, thank you very much. And I hear two important points here speaking out of you next to the many other important points to say. But it's important for the patient to have a collaborative care team around him. And the other thing is that it's important that we are all aware as doctors about the severity of the symptom itch and how burdenful it can be. And I want to now come to Gideon and ask him, how do you decide which patient needs a pharmacological treatment, and what is then your laddered approach to the treatment of cholestatic pruritus?
So thank you. I mean, I guess I actually do that in a number of ways, that, not just in the clinic room, but around the clinic environment. So around the clinic environment, I think there's a lot about awareness to diagnose PBC, and when you diagnose PBC, to ask about symptoms. So I really want everyone to raise their awareness of this rare liver disease and the impact of living with this rare liver disease, both on quality and quantity of life. Then I zoom into the patient in front of me, and I listen to the severity, and I look at any severity scores that they've got, and I look at the journey up to the point that I've seen them today and before and after, in terms of what I've tried and what they've tried, both, some of the things that Colette mentioned, and then I help them make a decision. Is it impactful enough that they want to take another medicine? And is that medicine going to be targeting just their symptoms, or is that medicine going to be targeting their disease and their symptoms? And we're going to mix and match. So I still use bile acid sequestrants, although they're not the most tolerable of drugs, and patients don't particularly like them all the time. Constipation, GI upset with cholestyramine, those kind of sort of bile acid resin drugs. Okay, so I think they can have a role, and they're very safe. We then have a choice, and we have a choice that includes drugs such as rifampin, which is actually quite effective. There are people already using off-label PPARs, but we're really excited the fact that there's going to be drugs that are being developed to treat PBC using this mechanism, which may also help itch, and that will increase the opportunity for our patients to have, licensed therapies in a safe way for this lifelong disease. And then I've got a choice. I've got a choice of drugs such as gabapentin. I've got a choice of drugs occasionally such as sertraline or naltrexone. And I think what happens is that you find your own recipes that work for that individual in front of you, okay? And you're using your bile acid sequestrants, you're thinking about your PPARs, you're thinking about the role of rifampin, and you're thinking about the role of particularly, say, gabapentin. But all along, what you're really excited about is the fact that the new therapies coming, okay, are going to target this in a much more scientific way. Because now we've seen clinical trials where the trial has included either disease control and the control of itch, and that's in its pre-specified primary analysis. So it's been robustly, designed, and we've seen drugs, meet those endpoints. Or we're actually developing drugs just for itch, regardless of your blood tests, regardless of what your skin looks like. You have PBC and you're itchy. That's enough to get into the clinical trial. It's not about the severity of the liver disease, it's about the severity of the symptom. And we're seeing drugs, EBAC inhibitors in particular, where the early data suggests very effective. And we've seen that those drugs actually applied to our pediatric patients with other rare liver diseases, where patients and particularly parents are saying, wow, these EBAC inhibitors have really helped the itch. Yes, there's still the disease, but the child feels better. And we're now waiting for that data to come from adult studies, which include people living with PBC, people living with PSC, where these trials are being conducted. So again, I like the term toolbox. I like the concept of patient choice. I like the idea that I'm doing it sequentially. I like the idea that I talk to the patient and say, well, we're going to try something, but we're going to review how it actually works. Okay, but I want you to just try and then come back and tell me. I'd say that, with awareness, with the current tools, but without future tools, really we're going to have great impact. And finally, I think Michelle's mentioned it and Colette's mentioned it, collaboration, patient charities, liver nurses, dermatologists. It's all there for us to really improve things.
Gideon, thank you so much. I know the question was very broad, from diagnostics to what is in the pipeline, and you covered this really very, very good and very briefly. And I think what's in the pipeline is very exciting. But to take this a step further, we should think about what are treatment targets. When I summarize all of your statements, I think it's, of course, the itch intensity, but maybe these are also the other symptoms like sleep and quality of life that should be improved. And then we know we're on the right track. And with that, I'd like to thank you very much for your important contributions and for this exercise today. Thank you.